Why is early diagnosis such a challenge to clinicians? And what's the importance of timely diagnosis and early recognition? Dr. Autry, could I ask you to address this question?
Sure, thanks, Jeff. I think it has to do with perhaps a misperception about the value of what diagnosis treatment can provide. There's an issue of proficiency for clinicians. There's issues with knowledge, I think, and time and resources. And I think all those things are actually surmountable with better education and appreciation that when you look at Alzheimer's disease and related dementias in a spectrum, and when you add family education and care of the caregiver, early detection where individuals are at their highest peak to be able to make their own decisions, to have this autonomy empowerment, to make decisions about their own lives, get on medications, change lifestyles, and have a supportive environment, that these are actually meaningful. And this is something that cannot be addressed by one demographic or one stakeholder. It requires healthcare systems to be involved, clinicians, educators, and family members. And I think over time, what's going to happen is, we'll have a bit more clarity regarding what are the pathways for best practices. And I'll put in a plug because we've been working on this in a multidisciplinary work group for the Alzheimer's Association for clinical best practices. And we're trying to actually put together 19 recommendations will come out later this year regarding the whole process of evaluation from in the primary care setting, in the specialty setting, in the subspecialty setting, including how to take concerns, how to do the evaluation, what testing to do, what are the level of recommendations regarding imaging and other biomarkers, and how to actually disclose this. So I'm actually really hopeful that we can reach primary care clinicians and help them implement these recommendations, but it's going to require, I think, multiple stakeholders to make this happen.
Yeah, that's great. I'm looking forward to those. Dr. Sabah, let me ask you to address the question of when should a healthcare provider refer to a neurologist when the question is Alzheimer's disease?
I think that the answer is very simply is that when the healthcare provider takes the time to detect that there's a cognitive issue to begin with, when they don't know what they're dealing with, when their comfort level is not where it needs to be, when they need a confirmatory approach to their diagnosis, and to not dismiss it. So in other words, I think most of the time, a primary care physician, when they detect any incident cognitive impairment, should warrant a neurological evaluation. Of course, we want to make sure it might not be Alzheimer's, it might be something else. But I think that's our best approach, is kind of push the patients into the specialty practice sooner than later.
Great, thank you. And Dr. Isaacson, I want to talk a little bit about non-pharmacologic approaches to Alzheimer's disease. We talk a lot about drug therapies, but what about the non-pharmacologic therapies? How do you think about them? When would you integrate them?
Sure. So there are now multiple randomized controlled trials that have evaluated whether lifestyle interventions may reduce the risk of cognitive decline. And really the totality of evidence is building that whether you take a multi-domain intervention, for example, there's a study called the FINGER study that used nutritional intervention, exercise on a regular basis, as well as cognitive training. When you use all three of these, there was less cognitive decline 2 years later in a very large, multi-country, very large randomized study. Then other studies have shown, for example, the SPRINT Mind study. SPRINT Mind study showed that, well, blood pressure reductions can actually reduce the incidence of mild cognitive impairment. And these are preliminary results, but these are convincing. These are randomized studies. And the studies go on that are looking at whether exercise, nutrition, cognitive training could have a benefit. But there's other interventions as well that may be evidence-based and safe. The totality of evidence may not be as strong, but minding someone's sleep, understanding going to bed the same time every day, taking away some of the sedative sleep meds and maybe using something like sleep hygiene rather than that. Music interventions have a very interesting body of evidence that's evolving. Stress reduction. These are all non-pharmacological approaches that can help in the treatment of Alzheimer's disease. Now, whether or not they're effective may depend on the person. Also, one-size-fits-all approach isn't going to work in a situation like this. And also just telling someone, go exercise, it's good for your brain, that may not work either. What if someone has a physical limitation, right? What if someone has low muscle mass? Well, then maybe they need to do strength training once or twice a week. But maybe if someone is not fit from a cardiovascular perspective, they need targeted advice on how to do cardiovascular exercise in a way that's appropriate for them. Maybe they need a personal trainer. Maybe they need to see a nutritionist. So the take-home point with non-pharmacological strategies is I really believe this should be a common, everyday part of the treatment strategy and the treatment armamentarium for Alzheimer's disease.
And is there a place to go to get information about this, Richard? It seems complicated to me as I listen to you.
It's quite complicated. So there's a variety of websites out there. There's a variety of resources. We actually created a free resource for the public. It's called Alzheimer's Universe. It's a free website that has just over 2.5 hours of coursework, interactive education about brain health, about what is and what is not in our control when it comes to risk reduction for Alzheimer's disease. The site, again, is Alzheimer's Universe, and it's at alzu.org. There's courses for high school students, college students, the general public, and also healthcare providers, medical students, and neurology trainees.
Very good. Thank you for that. And Elaine, what do primary care physicians need to know about treating patients with Alzheimer's disease? What are the critical things?
Well, I think there's some things they need to know even in a larger sphere than just treatment. I think first of all, primary care physicians need more confidence with making the diagnosis. Making the diagnosis of Alzheimer's disease that presents in the typical fashion, insidious onset and gradual progression of memory and other cognitive impairments in the absence of stroke, in the absence of Parkinsonism. You've ruled out B12 deficiency, thyroid deficiency. You've stopped medications that may be causing cognitive impairment. The vast majority of those cases will be Alzheimer's disease, and in later life, late 70s, 80s, it'll be Alzheimer's, maybe with another 1 or 2 comorbid pathologies. And I think that it's important to engage the quote caregiver, and early on in the course, and certainly in mild cognitive impairment, it may not be in the caregiving role, but they are in the information providing role and in the implementation of your recommendations role. And again, patients with Alzheimer's disease may have insight affected early, and they need to have that other source of information, and also for taking their medications and for complying with all the non-pharmacologic approaches. But also, not only will their Alzheimer's be better managed or managed at all, but all their other concurrent medical conditions will also be better managed.
Very good. Thank you. And thank you for watching. Thank you to our great panel.